the T wave and get blocked. Third, it can conduct with an aberrancy. So this is getting blocked and leading on to this pause. But this patient, what I'm trying to insist on is, why I showed this ECG is, as compared to the previous ECG, that this patient does not require a pacemaker. This pause is not a pathological pause. This is only because of a premature atrial complex which is coming and blocking into the ventricle. It's not conducting down into the ventricle. So these patients, you have so many patients who have respiratory disease, who are smokers, who are on some kind of steroids. I mean, anything, any catecholamine surge can cause a PAC in a patient. So all these patients are not a candidate for pacemakers. So we have to look at each and every P wave, QRS and a T wave also to see what this pause is all about. Whether the patient needs a treatment for this pause or does not need a treatment and should just be left alone. You know, some of these patients should be left alone. It's good. Okay, so the house agrees. You have any questions or queries, please come out with it. Yeah, okay. Should I go to the next ECG? Right? Okay, fine. Okay. Now, what is this ECG, please? Is it a normal sinus rhythm? Yes, no? Yes. Do you see a P wave proceeding every QRS? Because that is what normal sinus rhythm is all about, right? A normal P wave preceding a QRS. So we see a P wave before a QRS? Then how is it a normal sinus rhythm? Do we see a P wave in this ECG? Yes, no? No. What if I show you a P wave? Who said that, please? Excellent diagnosis. That's what is called as the eye to see an ECG. You have to find a P wave. He said there is a P wave following every QRS. Now I'm going to show you that. Do you see that hump behind this QRS? The best two leads to see for a P wave are lead 2 and lead V1. You see this lead 2. This lead 2 is not showing the P wave very well. But if you look at lead 1, see this. There is a hump at the end of every QRS. There is no P preceding the QRS, but there is a P following the QRS. See this? So this is a sinus suppressed but a junctional rhythm. The sinus is suppressed, but the junction is taking over. So patient has a rate which is okay. It's a narrow QRS, so the junction has a good rate. The rate is around 55-60. But the P wave is suppressed because sinus is slow. These are the junctional rhythms which we see normally sometimes after an acute MI or in patients who have a sixth sinus syndrome where the sinus is behind the AV conduction. AV conduction is faster than the sinus. At times it is pathological, at times it will just recover. Sometimes patients on beta blockers may have this kind of rhythm. You stop the beta blockers, this rhythm recovers. Okay, let's move forward now. Is the ECG clear on the back, please? Yes? Are you able to perceive the ECG right? No, yes. If no, please, there are a lot of seats in the front. You can just move forward. Because I'm sorry, I can't improve the quality of the ECG at the moment. I'm sorry. Okay, let's see. Is this a normal sinus rhythm or there is a tachycardia? Tachycardia. Narrow QRS or a wide QRS? Because once we see it is tachycardia, the rate has to be more than 100. We look at the morphology of the QRS, whether it is a wide QRS tachycardia or a narrow QRS tachycardia. So you think this is a narrow QRS tachycardia? Yes, everybody agrees? Okay. So this is a narrow QRS tachycardia. The rate is around, I would say 160 or 170. Do you see a P wave? Well, look at lead 1. Look at lead 2. There is a P wave following the QRS. The rate is around 160, 170. This has to be a, sorry? Excellent. It's a supraventricular tachycardia which has a very short re-entry circuit because the P wave is just following the QRS. It is a AV nodal re-entry tachycardia. Okay, I will just briefly discuss this. Let's see this ECG first. Sinus rhythm or a tachycardia? Tachycardia. Narrow QRS, wide QRS. Narrow QRS tachycardia. You see these, both the ECGs very frequently during your clinical practice every day. Patient presents to you with palpitations. He's feeling very restless, perspiring. BP is on the lower side. Heart rate is going fast, sometimes between 160 to 170, and sometimes this fast to the rate of 190 to 200. Do you see a P wave here? Yes. You see the P wave in between the two QRS, almost in between. It's out of the QRS, right? Can you perceive the difference between the previous ECG and this ECG? The P wave is outside. The rate is faster. The P wave is outside the QRS. That was just, in the previous ECG, it was just at the end of QRS. Why I'm showing you these two ECGs together is because this is another type of supraventricular tachycardia, whereby you have an accessory pathway. Accessory pathway which is conducting retrogradely very, very fast. Right? So this is a PSVT with the diagnosis of AV, re-entrant tachycardia. If you see this manifested on the ECG, you call it a WPW syndrome. Very commonly you see that. And if you do not see a pre-excitation on the ECG, you just call it a concealed pathway with the tachycardia, which is AV re-entrant tachycardia. Now, when you have patients of SVT presenting to you, the commonest maneuver in the clinics you can do is a carotid sinus massage to get these patients out of this tachycardia. In case you do not want to administer drugs immediately, you can try this carotid sinus massage. Why I put up this ECG is, the slide is, because normally I see the carotid sinus massage is not done in the right way. You have to know that you have to palpate for the carotid artery in the neck and give a very soft massage for about 30 seconds. Please do not press both the carotids at the same time because you can cause hampering of the blood supply to the brain. And in the patients who are elderly, that means above 65 years of age, you should avoid this maneuver because they can have some atheromas. With carotid sinus massage, you can dislodge those atheromas and they can have a CVA. Now, once you are doing this carotid sinus massage, you are increasing the vagal tone and the supraventricular tachycardia, it breaks to the either to the sinus rhythm directly or there is a block in the node and there is an escape rhythm. And subsequently, patient will have the sinus rhythm. This is another ECG which I have put up because in case the carotid sinus massage does not work in these patients, you do try a very commonly used drug which is exactly IV adenosine. Can anybody tell me how do you give IV adenosine? For the entire house, we have to know how to give adenosine.
Bolus.
Right, sir. It is given as a bolus. He is absolutely right. Preferably, please do not put an IV line in the periphery. Put it in the brachial cubital fossa and connect a three-way. Have adenosine at least 12 milligram ready on one syringe and about at least 10 ml of flush. Connect it to the three-way. Give adenosine bolus. Turn the three-way, give a flush. Adenosine has the efficacy to get you back, the patients back into sinus rhythm to the probability of more than 90%. In case it is not successful, it is because we have either not given enough dose or not the bolus. And you know, what I've seen is most of my friends who are the physicians who are referring, they say patient ko brady ho gaya adenosine ke baad. Now adenosine is supposed to cause brady because it blocks the node. This is what is the effect of adenosine which will happen. But why I'm showing you this slide is that rest assured, whatever you do, adenosine has a very, very short life. It goes, affects gives its effect on the heart and is just washed off before you know. So the rhythm, normal rhythm will definitely recover. Please don't be scared in case you find this kind of a response in the patient, that the patient is having tachycardia, you give adenosine and what happens is that this is the junctional escape